good afternoon, or good evening, depending on what time zone you're in. It's 8 o'clock, 8 o'clock in the morning here in Ohio. All right, so I've been asked to talk about lumbar disc herniations, and so I'm going to kind of focus on a couple of things, and then hopefully we'll bring some more stuff up in the cases. Whenever I think of lumbar disc herniations, I always think of these two quotes. The first one is from the French philosopher Voltaire, and Voltaire said that medicine is the art of amusing the patient while nature cures the disease. And the reality is, for the vast majority of patients with lumbar disc herniations, this is what we're doing. We're just trying to keep them occupied while they get better on their own and the natural history of the disease follows. And then the second quote I like is from the cover of The Hitchhiker's Guide to the Galaxy by Douglas Adams: "Don't panic." The number of people who get actually normally a self-limiting condition is kind of scary, actually. So now the other thing I want is, if you're only going to look at 2 journal articles, I've given you here the full here for 2 of them. You're only going to look at 2 journal articles to learn something about herniated disc. I think the 2 best are this article, which is the North American Spine Society's Guidelines Committee looked at all the and this reference, and you'll be able to get access to these, I believe. So this reference is that, and the most surprising thing as you read through this, if you ever do, is how little evidence we actually have for a lot of this in treatment that we use. And then this probably is the other key paper. This is the randomized controlled trial called the SPORT trial, done back about 10 years ago. And I will talk about this particular trial in much greater detail as we go through, because this is really this is probably the best information we have on treatment of lumbar disc herniations. So first off, what is it that we're dealing with? Well, the first thing to remember is that this is a clinical syndrome. It's typified by pain in the distribution of the affected nerve roots. So if it's L4, L5, S1 nerve roots, you tend to have the symptom of sciatica, which is pain radiating down the posterior thigh past the knee. If you have higher disc herniations, L2, L3, sometimes L4, you will have femoralgia, which is the equivalent syndrome, which is pain radiating down the front of the thigh. And with that, and so again, matching the nerve. Essentially, it occurs because there's a tear in the lining of the annulus and the nucleus pushes out. And this can either be a contained herniation, where you have a tear in the lining, but it's incomplete and a piece comes out, or it can be an uncontained or extruded or sequestered fragment, where there's a complete tear and the nuclear tissue is exposed to the canal. The pain is caused, there's a lot of debate over what actually causes the pain. Some people feel it's pressure on the nerve. Some people feel it's a stretch of the nerve. Some people feel it's inflammatory mediators. And there's a great body of literature looking at this. But it's probably a combination of all of the above that is the actual cause of the pain. You'll hear a lot of talk, there's the difference between a bulge and a herniation. Essentially, as we age, we all lose nuclear tissue. And so the disc tends to collapse a little bit. So the way to think of a bulge is to think of a bulge like the tire in your car or your scooter. As it gets low on air, the sidewalls bulge out. That's what a bulge is, and that is a normal phenomenon of aging, and in and of itself is not symptomatic and is not a problem. As I say, a herniation is where you have a tear in the lining, and it's a focal deformity of the nerve as well. So how does it present? Well, the typical is the sudden onset severe radicular pain. Often people will notice it while doing something, particularly bending forward. As you bend forward, it puts a little more pressure on the posterior annulus. But you'll also have just as many people who just wake up with the pain, or they cough or they sneeze. It can be anything that causes, if you will, or not, I wouldn't say cause, that it brings the onset of the symptom. Many of these patients will have a prodrome of back pain. So they will often say that, well, it started about 2 weeks ago. I had some pain in my back. It's been bothering me for about that time. And then suddenly today or suddenly last week, the leg pain began. And what's thought to happen there is that the prodrome of back pain probably is an initial tear in the annulus without a tear in the annulus without the herniation or without the extrusion. Excuse me, just a moment. I'm on call, so I have to answer this. This will be very quick. Okay. Sorry about that. All right. So continuing on. Some of these patients will have neurologic deficits, either weakness, numbness. Probably about 50–60% of people will have some form of neurologic deficit. Very rarely will they get urinary retention. This is what everybody worries about, Cauda equina syndrome. I work at a major academic center, and we have a group of 9 or 10 full-time spine surgeons, and we, between us, might do a half a dozen true Cauda equina syndrome patients a year in a facility that does 3,000 spine surgeries a year. So it is actually, the true Cauda equina syndrome is actually quite rare. So how do we make the diagnosis? Again, this is a clinical diagnosis. The diagnosis is made on the basis of the history and the physical exam. So you're looking for that pain radiating in the clear-cut distribution of a nerve root. You're looking for the nerve root tension signs. The classic one that everybody thinks of is the straight leg raise. So either in the seated or supine position, you raise the affected leg, and if it reproduces the leg pain, that is a positive straight leg raise. The other one to remember, if you're looking at physical exam signs, the most specific physical exam sign is actually crossover straight leg raise. So in crossover straight leg raise, you take a patient who has right-sided sciatica, you raise the left leg, and it reproduces the right-sided sciatica. That is about 98% specific for herniated disc, and is actually it's a more specific sign than the MRI. The way I look at the MRI is I consider the MRI to be a preoperative planning tool. I only get an MRI on a patient that I've already decided is a candidate for surgery, because you don't need the MRI earlier than that to guide all the earlier treatments. And so this is the classic MRI appearance of a herniated disc. You can see this large fragment here. This is actually a recurrent herniation because you can see the laminar defect here. But this is the classic appearance on a T2 axial of an extruded disc fragment, because you can see that this is at the level of the pedicle. So this herniation is below the disc itself, and therefore is extruded. So if we're going to treat a condition, either surgically or non-operatively, we need to know what the natural history of that condition is. And so what is natural history of the condition? Many natural history studies show that essentially about 80%, 80 to 85% of people will resolve regardless of the treatment that is used. And that's why I brought up the Voltaire quote earlier. There's all sorts of non-operative treatment that's been postulated or is done, but the reality is it's going to get better in the majority of patients in spite of what we do, not because of what we do. For many years, it was thought that extruded or sequestered fragments were more likely to come to surgery. It turns out it's the exact opposite. What happened is a lot of the early studies were done here in the US, where there's an excess of spine surgeons, and it became a self-fulfilling prophecy. The patients with sequestered or extruded fragments were more likely to have severe neurologic death. So in the United States, that was the indication for surgery. But natural history studies, particularly done in Japan, Canada, and Europe, showed that the sequestered fragments are actually more likely to resolve. And that's thought to be because the body recognizes nuclear tissue in the canal as non-self, and it sets up a very intense inflammatory response, which is why these people hurt more. But it also leads to reabsorption of the fragment. And there's actually a study that shows the bigger the fragment, the more likely it is to resolve. When we look at how people are getting better and we're following the natural history, there's a very predictable pattern of recovery. Pain is always the first thing to improve. Then power starts to improve, then endurance, and last is numbness. And numbness will, in patients who have significant numbness, so looking at it, 80% or more will get pain improvement, 80% or more will get power and endurance improvement, but numbness improves in only about probably 65, 70% of people. So many people will be left with persistent numbness if they have that as a presenting symptom. And again, most neurologic deficits will resolve without surgery, and I'll talk a little bit more about that as we go on. So this is the condition that we're dealing with, and then we want to look at how is it best treated. So what are the treatment options? Well, again, the goal is in the initial phase is to get the pain under control and get them to return to activity, because that's the goal. So when we look at what non-operative treatment has been suggested, obviously a lot of people consider physical therapy, particularly there's a lot of advocates of the McKenzie extension-based exercise protocol. Non-steroidal anti-inflammatories or oral prednisone have been recommended. Narcotics are often used, and membrane stabilizers, and epidural steroid injections. Now, what's interesting is if you look through the NAS for all of these treatments, there is insufficient evidence to make a recommendation over whether they're effective or not. None of these has been subjected to a rigorous, enough of a rigorous trial that the people doing the guidelines, with the exception of epidural steroid injection. An epidural steroid injection has been shown to be effective for the short-term management of pain. Again, the point in persisting with epidural injections for long periods of time, the goal here is controlling the pain to see whether this patient is going to follow the normal natural history, symptoms are going to resolve, or whether this is a patient where the symptoms aren't going to resolve, and then you're going to look at potential surgery for treatment. So what are the indications for referral to a surgeon? Well, if the majority of them are going to get better on their own, reason to send them into a surgeon is that they're not getting their own. And I sort of look at, I want people to have about of non-op care. If they're not getting better, referred in, because it usually takes me a few weeks to get them in to see me. And then by the time they get on my OR list, it's a few more weeks beyond that. And so I've gotten out past the time of the natural history. Debatable whether the severe neurologic deficit needs a surgical referral right away. And again, I'll go into that a little bit more later. Certainly the Cauda Equina syndrome patient, that rare patient with bowel and bladder dysfunction and saddle anesthesia, should have a surgical referral early. So I'm going to talk now in relative depth about the SPORT trial, because as I say, this is the best evidence we currently have for the treatment of lumbar disc herniation. So what is the SPORT trial? So SPORT is it's a series of trials, actually. There were 3 of them. There was one for lumbar spinal stenosis, there was one for degenerative spondylolisthesis with stenosis, and there was one for herniated discs. These were funded by the National Institute of Health. There was no corporate funding involved. There were 2 arms to the SPORT trial. There's a prospective randomized arm, and there's an observational cohort. So what happened is, if patients who came in to any of the participating centers were asked if they wanted to participate, and the patient was given the option of going into the observational cohort or going into the randomized cohort, and they followed both cohorts. They've now followed them, and they've reported actually 8-year results on these now. So it was the patient decision whether to go into the randomized trial or not, and then the randomization happened after that. So the inclusion criteria, they had to have symptomatic herniated disc with more than 6 weeks of symptoms. The average time of symptoms is actually closer to 3 months in the trial. Have a positive straight leg raise if they had a lower lumbar herniation. If an upper lumbar herniation, they had to have a positive femoral stretch, which is the upper lumbar equivalent of symptoms. patients who were unable to get an MRI, a CT was acceptable, and 3% of the patients, the operation was done based on a CT finding rather than an MRI finding. The surgery that was involved was a standard open microdiscectomy. They weren't looking at minimal access or tubular techniques. It was a standard open microdiscectomy. And the usual care patients got physical therapy, nonsteroidal anti-inflammatories, education, home exercise program. There was a real mishmash of non-operative care, and that was part of some of the criticisms of the trial as time went on. So what were the results? So the primary outcomes they looked at were in an intent to treat analysis. The primary outcomes were the SF-36 physical component score and the Oswestry disability score. Multiple secondary, 501 patients randomized, so this is a good sized trial, and 472 completed at least some of the follow-up. And they had a better than 85% follow-up even at the 4-year mark. By the 8-year mark, it's down to about 65%, which is still pretty good when you look at how big a group this was. So again, 73 to 86% follow-up, and they're now out 8 years rather than 4 years. Now here's where this trial gets into a little bit of problem. They did allow crossover. So if a patient was randomized to non-operative care and they felt they weren't getting better, they were allowed to switch to operative care, and vice versa. Patients who were in the operative, randomized to the operative arm, were allowed to cross over. So the primary analysis of this trial was done as an intent to treat analysis. So when the patient crossed over from surgery to non-surgical treatment and vice versa, they were still analyzed as though they'd had the original treatment. So a patient randomized to non-operative care who was treated with surgery eventually was still considered non-operative care in the primary analysis. So when we look at what non-operative treatment was done, about 2/3 of them had anti-inflammatories, about half had opiates, a little more than half had epidural injections. Interestingly enough, 67% of patients had already been through physical therapy on enrollment in the trial, and only 46% got further physical therapy during it. So when we look the operative treatment, you can sort of look and compare how this looks compared to yours. The average operative time was 75 minutes. This was knife to close, not total OR time. Estimated blood loss was 50 cc's on average. There was one unrelated death, post-op death. It was actually a childbirth, death during childbirth at 11 months out from surgery. 4% of patients had dural tears. 4% had a reoperation rate by the 1-year mark, and 50% of that, so 2%, recurrence within 1 year at the same level, which is actually lower than most studies quote for recurrence rate after this. So here's where the trial got confusing and a lot happened. So 50% of the patients who were randomized to non-operative care eventually had surgery. 40% of the patients randomized to non-operative or to operative care never underwent a surgery. So when you get these kind of numbers of crossover, essentially an intent to treat analysis becomes meaningless. Because you don't really have good groups. But if you look, patients with lower income, with higher initial Oswestry and PCS and VAS pain scores, higher symptoms, and those who were getting worse at enrollment were much more likely to cross over into the non-operative, into operative from the non-operative group. Older patients, higher income, lower ODI, higher level disc herniations were more likely to cross to non-operative from operative. So even the crossovers showed, if you will, bias. So the more symptomatic people tended to be more likely to want surgery. The less symptomatic people tended to be more likely to want non-operative care. So what did the study show? What was the outcome? At all time point studies, both the operative and non-operative group improved. At all time points, The primary outcomes favored surgery. So the surgery patients did better, but not enough to reach statistical significance in the intent to treat analysis. When you look, though, however, at the as treated analysis, so they then looked at and they took all the patients who had surgery and analyzed them as having had surgery, and all the patients who crossed over to non-operative care were analyzed as non-operative. They showed that operative treatment was clearly statistically significantly better at all time points. The other thing that is often thought in these is that previous studies of lumbar disc herniation treatment always alluded to a regression to the mean, meaning that the patients would do well early, but that over time the results would converge, and eventually you look at the Weber trial from the early 80s. The Weber trial showed that at 10 years, at 5 years, they were almost equal, and at 10 years, they were equal. What is interesting as we've been following the SPORT trial is even now at 8 years, there's not only no regression to the mean, it's actually the opposite. At each time point, the surgery patients are doing better, and that gap is increasing between them. So this trial caused a lot of controversy when it came out, and those of you watching this who have a little bit of gray hair, who remember this will remember all the stuff that went on with this. So the original press reports, so the Journal of the American Medical Association released a press release essentially saying that surgery was no different than non-operative care. That was the primary point of the press release, and that was the primary thing that patients were, or that the press was reporting when this trial came out. The Journal of the American Medical Association, the original plan for the journal was to print Kaplan-Meier graphs, graphs of the VAS showing both the intent to treat and the as treated. And the editors of the Journal of the American Medical Association would not let them do that. They minimized the as treated. And if you notice, if you look at all of the studies now, all of the follow-ups from SPORT and the other two primary trials, they didn't submit it to the Journal of the American Medical Association for any of the others because of this. They were concerned that JAMA was going to do the same thing and was going to minimize the as treated analysis. So there was a lot of confusion as to what the real results were. But the real results were clearly that surgery was better, and that was also confirmed with the observational cohort. So what does all this leave us? What can we really say about the SPORT trial? So those patients who had surgery did better, but also they were selected. These were the patients who were worse off to begin with. So the more pain you had, the more disability you had, the more likely you were to come to surgery, and you were likely to do better, which I think is a really strong conclusion. This is also really important. There were no significant complications to non-operative treatment. So nobody had a progressive neurologic deficit that got worse during the non-operative care. Nobody developed a Cauda Equina syndrome. Nobody ended up paralyzed. You know, all the things that patients are often told is going to happen to them if they don't have surgery. So essentially what we're left with is, in very symptomatic patients, surgery is a very good option based on this trial. And in less symptomatic patients, non-operative care is also a really good option. And so the goal here is you basically present the patients with the options and let them make the decision. If they don't feel their symptoms are too bad, it's entirely reasonable to treat them non-surgically. If they're really in pain, I think surgery is this study shows pretty clearly it's a good option. So the beauty of the SPORT trial is they collected so much data that they've been able to do a lot of subgroup analyses. Now, subgroup analysis in a randomized controlled trial is not really, it's not that valid there, you know, because you get biases and things like that. But I think it does provide really important information. So a lot of post hoc analysis. Workers' comp patients did improve with both treatments, but there wasn't a statistically significant difference between the operative and non-operative group in the workers' comp patients. So workers' comp is kind of a toss-up whether surgery or non-operative care is better. The 4-year results, surgery was clearly better at all outcomes other than work status. So return to work was equivalent by 4 years. Return to work was better for the surgical patients at 2 years. So there is a little bit of regression to the mean there. Similarly, at 8 years, that has held steady. They actually did a cost-effective analysis looking at dollars per QALY, and they found that at 2 years it was moderately cost-effective, and they suggested that if the results continued at the 4-year period, that it would be significantly cost-effective, and that has been proven to be true. So it is a cost-effective intervention. And this is one that often, I don't know, when I was trained, we were always taught that surgery for herniated disc would treat the leg pain, but not the back pain. Patients who had significant back pain did better in terms of back pain with surgery than the non-operative patients. So yes, surgery for herniated disc will improve back pain in about 80% of patients. They also looked at the role of mental distress in outcomes, and they measured mental distress based on the SF-36 mental component scores. And what they showed is that all patients with what they defined as mental distress had worse symptoms at inception into the trial. They had worse scores at all time points, and this kind of matches with what we all know. Patients with mental distress don't do as well. But what was interesting was that they actually had a higher treatment effect with surgery, meaning they started out worse if they had high mental compression or mental component scores, and they ended up worse if they had high mental component scores, but the actual improvement was actually higher in the patients with mental distress. So if your patients without mental distress got a 20-point improvement on the osostry, the mental component, the high mental distress patients had a 23 or a 22 improvement. So they actually made more improvement, although they were still more miserable as a result. And that's just a reflection of how mental distress affects pain. And then they went back and looked at the workers' comp results again and found exactly the same thing. The workers' comp patients started off worse, but the treatment patient or the surgery patients had a higher treatment effect. So although they started worse and ended worse, they made more improvement done. And again, that was done as a post hoc analysis. So in conclusion, what do we, for the sports study, and I'll go on to a few other things, what do we know from the sports study? Well, surgery shows benefit over non-operative patients at all time points out to, and it's now 8 years. In less symptomatic patients, non-operative treatment is reasonable. Psychologically distressed patients get more benefit from surgery, but they don't do as well as non-distressed patients overall. Again, we kind of knew that already. So now I'm going to look at a few more specific questions that are often asked. So in the patient who presents with a neurologic deficit, are they going to do better with or without surgery, or is there a difference? So in the SPORT trial, there was no difference in the patients with a neurologic deficit, whether they did better or whether they had operative or non-operative treatment. Another study that looked at this is part of a European randomized controlled trial done similar to the SPORT. And what they did is they looked at 150 patients in this trial who at inception had at least 6 to 12 weeks of documented weakness. They defined weakness as a motor score of 3 or less. These patients were then randomized to immediate surgery, and immediate surgery was done within a week, or prolonged conservative care. And what they found is that the patients who had surgery recovered more rapidly. By 6 months, the surgery patients were doing better, but not statistically significant. And at 1 year out, 80% of the operative patients and 81% of the non-operative patients had returned to normal motor scores. So there really isn't any documented benefit in the longer term that surgery is going to improve a motor deficit. There may be some role to be said for speeding up the recovery. They may recover a little more a little more quickly with surgery, but at 1 year out, it's not going to be any different. Another question that often gets asked is the timing of Cauda equina syndrome. When I was a trainee, it was said to be a surgical emergency. You had to operate on them within, and everybody had a different number of hours. But this was one of the few things that you would actually do in the middle when I trained. There have been a lot of looking at it. 2 recent studies, and the references are there. One, there was no difference in the surgery if it was done before 48 hours. Another showing 24 hours, no difference from surgery. There was a big database study that showed better short-term outcomes, and the outcomes they were measuring were things like hospital stay, chance of going to somewhere other than home, or sort of going to a rehab or a skilled nursing facility, and things like that. Really not the outcomes that really matter, and they did not show any correlation with neurologic deficit. So the sooner you got them to surgery, the sooner they got out of the hospital, but nothing really on the neurologic injury. Probably the best data is this study by DeLong. This is a meta-analysis of all of them. And what they found is there have been a few of the studies that have broken Cauda equina syndrome into incomplete Cauda equina and complete Cauda equina. So a patient who is having trouble urinating is an incomplete Cauda equina syndrome, and somebody with urinary retention or overflow incontinence is considered a complete Cauda equina syndrome. And what they found is that, first off, multiple studies have shown the complete Cauda equina syndrome patients have a much poorer outcome. Probably only about 30 to 40% achieve normal bladder function if they've had a complete Cauda equina syndrome. And what this meta-analysis showed is if they are incomplete, it seems as though surgery less than about 36 hours does better, but in the complete Cauda equina syndrome, the timing of surgery really doesn't matter. They're not going to do well regardless of when you get it done. So that's probably the best recent data on. So coming back to when do I do surgery for these patients? So I want patients to have a minimum of 8 weeks of symptoms, and I usually try and wait it out to 12. If you look at the natural history studies, the vast majority who are going to improve will have improved by the 3-month mark. Probably about 75% have improved by the 6-week mark. About 85% have improved by the 12-week mark. They have to have pain that prevents them from doing activities of daily living. They have to have pain that interferes with their function. The other studies that have looked at it show that probably if the patient has symptoms for more than 12 months, they will have less good outcomes, particularly in the patients with back pain associated with it as well. So I definitely don't, and so I sort of look for a sweet spot. I try and operate somewhere between 3 months and 6 months, and try not to let it get out much beyond that. Again, urgently in Cauda equina, if I have a patient with Cauda equina, I want them in the OR in under 24 hours. Another big question is open versus MIS. I know there are some staunch advocates of MIS treatment looking at this, but I want to actually look at the data, not anecdote, not case series. Look at what the best data that we have. So very consistently, minimal access surgery shows shorter hospital stay, lower blood loss, less narcotic use, no difference at 1 year, probably lower infection rates, and fewer complications in the obese. And you can take those 4 bullet points and apply it to any MIS surgery technique in existence. Those are very consistent with any of them, and particularly with this. But what do we have in the looking at this is looking at translaminar or interlaminar discectomy. So this is the standard. I mean, this is what we've been doing for 50 years. It has very predictable results. It's flexible, it's extensile, and it's the same procedure as you do when you're doing a tubular type discectomy. Some of the endoscopic discectomies, particularly the far lateral transforaminals, are a little different. But when we look at I'm going to look mostly at using a tubular retractor, whether it be an endoscope or using a microscope. The outcomes at 1 year are no better, MIS versus standard. This study showed a little bit less pain medication requirements, a little bit less hospitalization. Those were the only difference. Another one looking at length of stay, blood loss, narcotic use were the only differences. So here's the problem with that. You know, if you look at some of the early studies that people quote saying that MIS is better, in terms of length of stay, one of the famous papers that gets quoted a lot had an average length of stay for the open patients of 2.8 days, or sorry, of 3.2 days, and for the MIS patients had an average length of stay of 1.8 days. Well, my average length of stay after an open microdiscectomy is 2.4 hours. So I don't think you can say that under current ways that most places are managing disc surgery, I don't think you can argue that hospitalization is shorter if everybody's going home the same day, or at least not significant. And when you look at the difference in blood loss in the German trial, the study by German, the difference in blood loss was 15 cc's. That, you know, is that clinically significant? I think I'd argue it wouldn't. It isn't. But if we look at what is the best available evidence, there are 2 systematic reviews, and both of them showed the same thing. Higher reoperation rates, more durotomies, more root injuries, and a higher rate of recurrence. MIS techniques as opposed to the open techniques. And that is why a lot of people, myself included, and those of you who know him, Mike Wang from Miami, who is one of the leading advocates of minimal access spine surgery, a guy who's doing minimal access pedicle subtraction osteotomies. He has gone back to a standard open microdiscectomy because his recurrence rate was higher in his MIS patients than it was in his open patients. So I think if you look at the best available evidence, it says at best, there's no difference. So again, looking at the reality, how much smaller an incision are you actually doing comparing an open to a microdisc? You know, is it clinically significant to have a 2.5 centimeter incision as opposed to a 2.0? I think you can argue that it isn't. You know, the current length of stay is meaningless. Most patients lose more blood in their preoperative blood work than the difference in estimated blood loss in the trials that have looked at it for this. Faster return to function, that's probably more likely surgeon driven. We do an MIS procedure and we say, oh, you can get back to surgery, you can get back to activity faster because we did the MIS procedure. There's actually no evidence that activity restriction, studies that have looked at activity restriction after microdiscectomy show there's no benefit to activity restriction, but we all do it anyway. And people who are advocates for minimal access tend to get their patients going more aggressively. And it's probably much more likely surgeon driven that the return to function is, or other people have argued that that's the cause of the higher recurrence rate. Anyway, I think the reason why it's so difficult to show a difference is that a current microdiscectomy is actually a pretty minimally invasive technique as it is. So looking now, moving on, what is the risk of recurrence? The figures that I always quote and I always remember is if you have one herniated disc and you have surgery for it, your chance of a recurrence, same side, same level, is about 10%. If you have a second one, the chance of a third is about 10%. If you have a third, the chance of a fourth is actually much higher. It's about 50%. And in the patients that I've operated on where I've done this, what I find is that the patients who have multiple recurrence have a huge persistent annular defect that just never scars over. And so that's probably why, is that they just don't scar over, and so pieces can keep coming out. There's really no good support for fusing patients after a first recurrence. That was common for a while, but there's really no good evidence for it. It's debatable after a second, but I generally, if somebody has 3 disc herniations, same side, same level, I generally offer them both. I say, you know, we can try the discectomy again, but there is a 50% chance it'll come back, or we can go straight to a fusion, in which case you've got the, you know, chance of adjacent segment problems and pseudarthrosis. And I let the patients make the decision. Most of the patients do tend to opt for surgery after 3 because they're tired of it. The risk of recurrence is more than doubled in people using nicotine, be it smoking or vaping, or chews or patches or gums. So nicotine definitely increases the recurrence rate. It is not affected by postoperative activity, so it is safe to let people to return to whatever they want to do. Which brings me to the last little part I wanted to talk about. In terms of, is it safe to return to full activity? Those of you who know American football will know that this is Joe Montana, who was a quarterback for San Francisco in American football. Joe Montana played for 8 years after a microdiscectomy at an extremely high level, winning the league championship on 2 occasions. So, there are examples of that. But I wanted to talk specifically about return to play in elite athletes. And this is a credit to a friend of mine, Wellington Sue at Northwestern, who's done a lot of work on high performance athletes. So he looked at 342 professional athletes who were treated between 1972 and 2008. 226 of them had surgical treatment, 116 had non-operative treatment. Overall, there was no difference in their ability to return to play. 82% were able to return to play with an average career length of 3.4 years. Now, remember, in American football, the average length of a career is only 3 years. It's a sport that kind of eats them up. And 62.3 of the patients were still active and playing 2 years after going back. So it is possible to return at a very high level. It is a little bit sport specific. They found that baseball players were more able to return to play than players. However, interestingly enough, the baseball players who returned to play tended to have a shorter career than the football players who were able to return. It was felt that in the NFL players, the American football players, that there was a higher return to sport if they had surgery than non-operative care. Watkins wrote a criticism of this article, which is interesting because a lot of the patients in that study were actually Watkins and his dad's patients. Watkins was really an early pioneer in this. But his comment is, you got to remember, you can't generalize this to your normal patient population. This is an incredibly selected and motivated group. Yeah, they need to get better in order to earn their money. They have phenomenal rehabilitation programs. And he said, most of it were football and baseball. So looking at other sports, there's I found one reference to return to play in cricket. And they found that everybody other than bowlers tended to be able to return. But bowlers, particularly fast bowlers, were less likely to be able to return to play. And it probably has a lot to do with the mechanics. Rowing is a notoriously bad actor. Because of the catch phase in rowing, when you're in maximum forward flexion, applying a maximal leg contraction and a maximal upper body contraction, so huge loads, and so rowing is probably the sport with one of the lowest ability to return to play after herniated disc. And when I was working at a university that had a very, very large athletic program, that was the only sport where we told athletes when we came in that there was a reasonably high chance that they would not be able to return. We would let basketball, wrestlers, football, baseball, we would tell all of them there's a high chance they'll get back to it. The rowers were the only one that we said that we couldn't guarantee a good result. So that's sort of an overview of where I'm at in terms of my thinking on herniated discs and what the literature shows. So in summary, remember that this is a clinical syndrome. It usually has a benign course. The vast majority of patients will not need surgery. There is no risk to a trial of non-operative care, even in patients with a neurologic deficit. It is reasonable to do a trial of non-operative care. Surgery, I think, shows better outcomes if they're not improving by 8 to 12 weeks. And most athletes should be able to return to play. Thank you. Let's go with some questions then. No questions.
We'll take a few questions and then we'll go to Benedict for the cases. Now I have a question. What is the reason for fusion in the second recurrence?
So the theory was to prevent the third recurrence. Because again, as you go with the number of recurrences after 2, the chance of a subsequent one goes way up. And as I say, it's usually because of a persistent annular defect. So the theory is by fusing patients, particularly if you do a fusion, you reduce the chance of another herniation.
Thank you. I will take my privilege as a host and ask one of my own questions before I go to the list. What do you do, or in a case where there is classical clinical radiculopathy, you see the solar nerve root on an axial MRI scan, but there's no disc herniation?
So what's usually happened in those patients is that they've had a sequestered fragment that has resorbed. And typically there's an injury to it's an irritation or injury to the dorsal root ganglion. And usually in those patients, I advocate for non-operative care. The only thing though, in those patients to back and have a really, really, really close look at the MRI, because what you'll often find is that in the sagittal cut at the index level, you will see a very focal, almost pointed disc herniation. And you'll often only see it on one cut. And what happens there is that a herniation in the axilla of the nerve root. Very pointed appearance is often an indication that the herniation is right in the axilla. So go back and look at that. But if you don't see that, then it's usually that's a patient who's had a fragment that's resorbed with some injury or irritation to the dorsal root ganglion. I think that's a good indication for using membrane stabilizers like pregabalin or gabapentin. Epidural injections seem to help there. And then I would just wait them out for a while.
Okay, thank you. So this is what we're going to do. We're going to continue with the questions and then start with Benedict's cases. And in the end, we also have a few results of our own questions that to the participants. Nick, can I just remind the participants to fill their feedback forms? It's very important for us. Now, the next question is, how much disc material should be removed? What is your choice for the herniated disc? And the other question is, what is your choice for the herniated disc and spondylolisthesis?
Okay, so the 2 questions. So the first, there's been a lot of literature looking at sequestrectomy, only removing the herniated piece, versus aggressive discectomy, trying to get as much nucleus out as possible. In terms of the radicular pain out is
I think I lost its connection, I think.
Yeah, Doug, we can't hear you, Doug. Doug, are you still here? We can't hear you. So Nick wanted to make a comment.
I wanted to ask Doug, what is his opinion on back pain and disc replacement? Seems like I see publications from US, more and more publications from US about back pain and disc replacement. I just wanted him to comment on that.
Sandeep, while we're waiting for Doug, would you like to answer that?
You know what? In the previous
So, sorry about that. Something happened with my internet. Can you hear me again?
Yes, we can hear you.
Okay, so there aren't any good recent studies looking at less aggressive discectomy techniques. Again, this is one. So this is one where I would have a long conversation with the patient. I think in a degenerative spondylolisthesis with a herniated disc, you're probably better off going to a fusion. In an isthmic spondylolisthesis, it has a lot more to do with did the patient have significant symptoms before, and what is their level of function. So if I had a professional athlete with a herniated disc, I would probably do just a discectomy, give it a try at that. But for most patients, probably if they have a herniated disc at the level of a spondylolisthesis, you're probably better off going to a fusion because they do have much higher recurrence rates.
Can I ask a question?
Sure.
Okay, I've just one question. In case you have a patient with a second disc herniation, recurrent disc herniation, do you inspect the annular defect and then decide maybe to place annular closure device?
I have not. I early on did some of the annular closure devices, and I had really, really bad experiences with them. So I have not.
What happened?
What happened? They displaced.
Displaced?
Yeah, so I got recurrent sciatica from a displaced annular closure device.
Okay,
and
perfect. Because
the problem is that they also, when those displaced, they were intensely inflammatory, and the redo was some of the hardest discectomies I have ever done.
Yeah, because recently we have done a couple of cases. I didn't do any of my own because I was very reluctant, but of those 25 cases, one completely it broke and then caused radiculopathy.
Yeah.
But if you look on the prospective randomized trials of those study groups, everything seems to be fine. And so I just wanted to get a second opinion.
I look at those trials. The other thing is that the trials that are looking at it they're talking about using it in massive annular defects. So it's 6 defect. I don't try and I try and keep my annular defect if it's a contained disc herniation. I try and keep my annular defect as low as possible. And if it's an extruded or sequestered, I don't go into the annulus.
Yeah. Absolutely. I think if you have a disc herniation, just remove the sequester if there is any loose disc material, which you can just pull without any force of the annular defect. This is fine. And we overlooked a series of patients who were treated with a Casper method from early on with a 30-year follow-up consecutively. And even though they had 30% reoperations after 30 years for several indications for set joint arthrosis and stenosis, they were happy with the result of the surgery, even after 30 years.
Yeah.
So we'll have 2 more questions before we go to Benedict's cases. I have a question from Nikolai Peeve, and Nick wants to know, Doug, what's your experience with disc replacements?
Well, sir, first off, disc replacement is not, lumbar disc herniation is not an indication for a lumbar disc replacement. First off, I was one of the early adopters of lumbar disc arthroplasty. I did my first one in 2001. I did my last one in 2005. I just, first off, it's who's going to benefit from. Second, the results were no better in any outcome, including reoperation rate, than an anterior standalone interbody fusion. So unlike the cervical spine, where I think there is a very argument to be made for a disc replacement, I think there is any indication currently for a lumbar disc arthroplasty.
Okay, so last question. How would you manage a small disc prolapse associated with a unilateral synovial facet cyst?
Again, I'll start with the conservative care always. And if the conservative care doesn't work, one option you have there, if it's a small disc and a big cyst, is there's good data now on essentially bursting the cyst. Fill the cyst up with saline until it bursts. It's really painful for a few minutes, but it actually works reasonably well. Otherwise, if I've got a patient with both, it's often difficult to know, since if you do screening MRI studies, it's often difficult to know if the herniated disc is actually causing symptoms or whether it's just the facet cyst. So what I do in that circumstance is I do a small laminotomy, I resect the facet cyst, and then I just look, is the nerve root mobile? So if you take a Penfield and just lightly tug on the lateral aspect of the nerve and it moves freely and easily, then it's probably that disc herniation is not causing symptoms. If the nerve root is at all tethered, then I would do a discectomy as well.
Okay. One quick question. Do you irrigate the disc space when you lose fragments once you're done with the discectomy?
Yeah, that's what I was saying. I take a 10 cc syringe with a 14 gauge angiocath on it, stick the angiocath into the disc and squirt 10 cc's in. If a fragment comes up, I do it again, and I basically do it until I no longer get a fragment. And essentially what I'm trying to do there is, as Benedict was talking about doing with just, lightly tugging on things, I'm just letting the irrigation decide which pieces are free floating and which